are fairly narrow, we've still got to be able to do distraction at most levels here. And it's kind of hard, as you can imagine. And so we need to get that under control. So let's just have a quick run through that protocol there, just very quickly. So it's 5 minutes, so it's in our minds, just one after the other. We can work in threes if you like. And then go into your pairs, just working down. And we'll answer Ralph's question. Nobody move until I've answered Ralph's question. Okay? Yes, Ralph?
How are you doing your rotation, Kevin? You mentioned it, but you didn't.
Oh. Didn't you see that? Was I too quick? Did you blink? You must have had a... Come up here, Bob. All I'm doing here, my rotation, the two ways I do it. One, on your stomach, please. One is simply to lift the pelvis up, like this. So I'm doing a left rotation. What I'm feeling is that the caudal bone is moving to the right, but I'm feeling it against the upper bone, which traditionally would be the way I would describe this. So this would be a left rotation of, let's say, 5 or 4 on 5 or something like this. And then I would come down here like this. Or I would do it, can you lay on your side? By simply coming here, putting a pillow under a head, and then just holding in here and pushing back. I'm glad you asked that question, Ralph. It's a good question. I would push back, and I would once again take up the curve of the spine here, so that if I were looking at the upper thoracic, I would be pushing a little bit like that, middle like that, lower, I would come down over the rib cage and move like that. So I'm not moving and confusing myself with a sloppiness in the shoulder. So in taking that curve, I would be doing that angle, and a little bit that angle to do my rotational movements. Just trying to bear in mind the curve of the spine.
Thank you.
Any other things? Good. Let's go to the beds and just go through that, and then let's try and do 3 or 4 techniques, all of which you've done. And I only want to sort of add 1 or 2 little bits and pieces of myself. In the thoracic spine, when we're kind of considering possibilities, a dural sign is going to be very significant, because it means that we're essentially only going to use a distractive mobilization at right angles to the curve of the spine, at right angles to the disc at that curve, because that's safe, even if it is a disc. They're supposed to be very rare, but with MRI it's sort of shown that they are less rare than was previously thought, but there's no more increase in the incidence of neurological signs because we've found MRIs. So are they all that significant? I don't know. If we get any of this though, bilateral lower limb paresthesia, altered hypertonicity of the lower limb reflexes, a positive upward going toe, the Babinski sign, clonus, altered bladder and bowel activity. Now, it's a very interesting thing though, that when you read that article, which I'm sure you will all be eager to read tonight, all right, you will see that one of the common things, and I usually show this, and I don't know whether I've actually got the, I haven't. I tell you what, let me ask one person in 3, so the other 2 don't look at this. This is so wonderful from Dave's work here, to be able to look at the index instead of me counting through page after page here. Okay, and it's H. Now, I don't want everybody to look at this. Yeah, find that for me, would you? H1. I haven't got my glasses on, so I can hardly see it. Okay, so you're the one that's going to look here. Okay, so we're into H. What is that? H1. All right, and what I'd like you to do is to just that one person to find H1. It's on the second page, and there's a diagram, a pain pattern. And I'd like you to put a piece of paper across what it is. That's like across the bottom. and I want you to let your partners have a look at this and see if they could come up with, even in their wildest dreams, what that is. The pain pattern. How would you have interpreted this pain pattern? So if one person could look at H1, and then we're going to H2, put a piece of paper across the little diagram, which you can see here, okay, across the bottom there, so that your partners can't see it, and ask them to look at it and see if they could come up with what it is. I mean, even you can do the same thing. You can just find that, not look at it, and put a piece of paper across the bottom. Just do that without kind of looking at it too much. So that's H2. Defocus your eyes and have a look.
What do I have to look at? What do I not look at?
No, you're just not looking at what it says it is. So you're looking at that without looking at the legend underneath.
Oh. What do you think this is? A band of tight heels.
This is legal anesthesia. I was off.
If you saw a patient like that, you'd think they were a nutcase.
I was. What my thing would be was T10, T12 visceral problem.
Anyway,
Rush feeling, a sympathetic influence.
Okay. Wonderful article, that. Wonderful article. Yeah, excellent. Okay, you can, once you've looked at it, perhaps if I could just go over this business, I better find my jacket and put on my glasses, I think, here. But I see I can't even see my glasses, and my jacket even. Okay, can you imagine a patient coming in and you're a bit behind, okay? And they say to you, geez, right under my rib cage here, I've got this kind of band of, I've got this rushing feeling or pushing feeling. And then I've got this band, a tight band here. And then in my right leg here, in the front of my leg here, I've got like a burning feeling. And it feels as though my skin has been rubbed with liniment. At this stage, you're kind of rolling your eyes about, okay? And then you look in the other leg, and at the back of the leg, in the back of the knee here, and the foot, same leg, they've got this problem. Okay, so in here, but in a different dermatome altogether, they've got pain here and sort of feelings there, a disagreeable, it just feels horrible. And you'd really look at this and think, oh golly, here, pain clinic material here. And yet, when you look at this, proven with this patient was a protruded disc at T45. Now, what I'm interested in on this diagram is the complete lack of any sensitivity down the back here. Was it not looked for? You can't imagine that they could have had all that and not have had quite a lot of sensitivity in the dorsal ramus. I'm really sort of surprised at that. But you look at this pain in the right thigh, pain in the right foot, back of the knee, these strange feelings. And the interesting thing is that in many of the discs that were looked at, the most consistent finding of all was a very disagreeable paresthesia in scattered areas below the level of where you thought the lesion was. And the very interesting thing is, it doesn't say, I don't think, in the text, and it's a while since I read that article, but I don't think it says as to whether there was very much change in these things. But I certainly know that one of the most consistent findings was that even in disc lesions that were fairly well developed, bladder and bowel activity remained in the control of the patient. This was consistently found, that it had to be really bad for this to start to be a major affection in the thoracic spine. So sort of thinking this is there doesn't necessarily mean that there isn't some disc problems. But for us it's a bit inadequate and a bit we'd like to know more. We'd like to know more about this, wouldn't we? We'd like to have some idea of these things. Were any of these? And that very strange thing as to why there was nothing in the posterior body wall when we're finding all this in the legs and so on. But if you remember that patients with a sort of disagreeable paresthesia, and then perhaps some symptomatology up here, and then in the lower part a disagreeable paresthesia, perhaps we should use that as one of the bells, one of the flags that waves for a thoracic disc lesion. Even in the absence of this full developed myelopathy, and even in the absence of this, we should think about multiple myeloma, night pain. Is it a primary lesion? Not too many in the spine, far more likely to get metastases, secondary lesions. Osteoporosis in the elderly, also in postmenopausal women. Long-term cortisone application. Ankylosing spondylitis as being an inflammatory arthritidese, not a contraindication to even fairly positive mobilization, but not in its active stage. And of course not in its stage where we've got bony blockage. Osteochondrosis juvenalis, Scheuermann's disease. Here once again, an inflammatory growth pad. So we would be a growth plate. So we would be very sort of cautious, but we could still mobilize in the correct direction. And the last thing here as a sign is multiple segmental rigidity. So all of those things we kind of consider when we've done our examination. Now then, we'll finish on this little theme because I know tomorrow in an hour we're going to be able to do most of these techniques because you were doing these very well today. And in the higher areas, when we get a bit lower, you shall have no trouble. This is quite a good diagram because sometimes you get a bit confused, don't you, lost when you start rolling patients around on their backs. If we have a contact on, this is the squared contact, on the same transverse processes of a vertebra, and then I take the joint, the caudal bone away from this, I will produce a distraction. If I pull it slightly forward, I stabilize this and I produce a flexion. And if I hold here and take this back, I will get a symmetrical action on both sides, which is the posterior glide and seems to go along with extension, although they're not two identical movements. Now then, if I have an asymmetrical contact, or let me just backtrack. If I have a symmetrical contact here and I deliberately induce a rotation above by actually rotating, then obviously I get a rotation. I gap the side, the facet that I'm going towards, and at that point I slightly lessen the diameter of the intervertebral foramen. Now then, if I have two contact points on a transverse process, symmetrical, and then I change it so that I have one contact point on the transverse process below and one above, and I do a symmetrical anteroposterior thrust with an asymmetrical contact point, I will produce an asymmetrical movement, which is rotation. And what happens is that I will gap to the side of the lowest contact point. So that when you have the patient in prone, which is a technique we don't use very much because it's very limited, chiropractors use it, and it's stiff and it fixes the ribs on a table, which might mean if you use a little inadvertent pressure, you might fracture a rib. So we don't use that position very much. But if I've got the patient in a supine position, like this, and I apply an asymmetric contact point, and I'm just going to use my contact like this, and it'll be lower on the thenar eminence than it is on the finger there. I know automatically that I'm rotating to the side of my thumb because that's the lowest contact point, and it gaps on that side. So even turning the patient over and doing this, I know that it's gapping to the side of the lowest contact point. I can go to the other side by just turning my hand up a little bit and making sure that the right side is the lowest contact point. Therefore, when I go through with my antero-posterior movement, it'll just rotate it to the right. So you don't get lost on those bad days, 4 o'clock in the afternoon, backing up with your patients, and you suddenly feel completely lost. You don't know where you are with what's going to happen here. So you have to back off and rethink. And very easy to think, oh yeah, I just want to rotate this particular way. I've just got to make sure that's the lowest contact point. And that does it. So this is very, very useful when you roll patients over, and it disorganizes you sometimes to be able to do that. So it rotates to the side of the lowest contact point if we have an asymmetrical contact like this. Now then, the only other thing that we should consider, and this will be a last thing today, is that rule of 1, 2, 3, 2, 1. What's that rule, Suzanne? The 1, 2, 3, 2, 1 rule.
Oh, that's
Yes, go on, Sandy.
that's finding the transverse process.
Yes. And what does it mean? Let's start with the 3.
That I suppose you said that in the mid-thoracic spine, if you're on a transverse process, if you're on a spinous process, then the transverse process to that same vertebrae is going to be 3 finger breadths.
Yeah, 3 of the patient's finger width. So between the 5th to the 8th, if we put our fingers on here, it would be 3 of the patient's fingers width to find that transverse process. If we go 3rd and 4th, it'll be 2. 1 and 2, it'll be 1. We go to the other end, 9 and 10 will be 2. 11 and 12 will be 1. And
4 through 8?
no, 5 through 8 will be 3. Then 3 and 4 will be 2. 1 and 2 will be 1. And then the other end, after 8, 9, 10 will be 2, and 11 and 12 will be 1. And if we're taking transverse processes, we should know that, shouldn't we? Because we're sort of saying we're accurately moving one joint. So just compare the patient's fingers with yours, just get a rough idea of if you're like 1/3 of a finger wider than the patient's, and you can put your fingers on their back and just sort of assess that more accurately than has been done in the past. It's a good little rule to remember. Do you like that, Suzanne? Good, thank you. Very well. Tomorrow we'll be straight into this. There's about 10 or so, well perhaps not 10, 7 or 8 techniques that we should do, but all of you have done lots of techniques before. I want to be sort of using non-congruent locking, and then of course we'll be moving into the ribs where we'll have 4 or 5 techniques to do and some assessment procedures that I think will be useful for you, and then will be 4 or 5 techniques on sacral. Today we've got to do just a few techniques in the sacroiliac joint, and I'm not going to do 100,000 techniques. If you look at all of these with the changes of leverage and stuff, what you're seeing is the variation on a theme, and so long as you understand what the theme is, you can do the variations yourself, and we'll sort of go fairly rapidly through that.
Would it bother you if I turn this light on?
Nope.
Lighting is
Ah, that's better. That shows who's important. Okay. So we've got the sacroiliac joint to do. We've also got the thoracic spine to do, and I'm sure that all of you will be moving through this fairly rapidly, looking at yesterday when we did the thoraco-cervical junction, and that's quite a difficult area to get at, and yet people were doing that quite well with stabilization and so on. So when we get into the middle part of the thoracic spine, like T4 down to T8, relatively easy to do. When we get past T8, T9, it becomes a little difficult again because we've got large levers that we're dealing with, and we have to control those levers. Otherwise, the patient tends to go into an extended position. Now, I've mobilized and given impulses to people that I know have got some degree of questionable thoracic spines, and I've never had a problem. And I think that this is because we've developed much more the supine positions. They're more difficult to control initially, but indeed they are so much more versatile. The tendency for this area, isn't it, is to go into what? The kyphus position. When you see people that become dysfunction, you very rarely see anybody that's dysfunctional back here. It tends to go into an exaggeration of the primary curve. And so it is a flexed movement here. And if we take a flexion of the spine and we place the patient in a prone position like this, the tendency for nearly every technique will be to push into an extended position, be it an engagement of the transverse processes with rotation or attempting to do some kind of a separation of the facets. Is it possible? Probably not possible even in this position, but it forces the patient into a position away from the neutrality of the kyphosis. And the other thing that it tends to do is to put stress on the anterior ribs when we do this. Now, in the rib fractures that I've seen, and I haven't seen very many, and none of them have been related to manipulation, I'm talking about just people that fracture the ribs, it seems to me that the fractures take place in the lateral area here. I haven't seen fractures myself of the neck, although I'm sure that this would be somewhat possible, but the neck is very, very much supported by the transverse process, and as you know from Diane's course, there's a multitude of ligaments attaching the neck to the transverse process. And if we can keep close to that while we are doing any contact, and we don't stop the front of the ribs from moving, the chances of getting a fracture in this area, because we've done equivalent of what the muscle energy people would call a rib compression, are obviously fairly slight. So we will spend most of our time looking at the supine positions because it's very versatile. We can do distraction, we can do posterior gapping, we can do a little extension over our hands, and we can do rotation. Whereas with the supine position, we can do rotation fairly well, but the problem is all of the other things, and certainly distraction, are not possible. So I don't think we should spend very much time doing this. I can't remember the last person that I manipulated in the prone position, although we learned this. And indeed, Dr. Syriacs did a lot of this, but he used to put his traction on. He used to have his therapists, one pulling on the legs and one pulling on the arms, and then doing a motion like this. I remember I had Stephanie Saunders in one of my groups once when I was kind of lecturing with the North American Academy of Manipulative Medicine. They kind of slummed it for a while and asked a few therapists to lecture. And it was kind of interesting that you go into this group and everybody's leaping on the backs and everything, and the two people who were teaching the Syriacs things in Canada, Stephanie Saunders and a physician from Ottawa, came to me afterwards and said, you know, we've definitely been using far too much force here, and we think we should adapt our techniques to what you're teaching. So I think that we're on the right lines with the thoracic spine in terms of it being an exciting area to treat. It's very satisfying to treat, and we're not going to get, with the protocol that we're using, in very much trouble with this. And even if we do it in those cases that I was discussing yesterday, that transpire down the road when it's not cleared up that it was an inappropriate technique, the technique itself had inherent safety, so we didn't end up doing something inappropriately dangerous to the patient. So we remember those disease processes of yesterday, the inflammatory arthritis, the metastases and the primary tumors, and the osteoporosis. All of those are very important things. and it would be advisable when we have those kinds of patients for us to be basically using controlled mobilization, of course, if mobilization is indicated. So let's just think about the techniques of manipulation in the supine position. So we're going to use our classical technique with the hand. Did you lose a Gucci watch yesterday, Suzanne? A watch? Did you lose a watch? Because we found a watch and nobody is agreeing to it. No? That's the watch.
Oh, come on, Suzanne. Yeah, that is.
And we're going to let Suzanne loose on the thoracic spine. Okay, let us continue. All right, let's think about the thoracic techniques which we've done and you've done recently. All right? I've just made some comments on the film that we've just been doing, and I'll reiterate them now. And hopefully I'll remember that I've said it to all of you and not just on the film. That when we look at the thoracic spine, our contact points are going to be on the transverse processes. And we can either use symmetrical placement, as we discussed yesterday, of the caudal bone, which means that the cephalic bone can be posterior glided, or it can be distracted, or it can be taken a little into extension. If we do a distraction, it's going to produce those distraction of the discal joint and a glide, a cephalic glide of the zygapophyseal joint, which will restore flexion. If we do a posterior glide, which gives us a gapping of the zygapophyseal joints, even though this is not the same as extension, which is the movement down like this, it still seems to restore extension. So we're not going to have patients like extended over our hands to any great degree. We'll try and maintain the kyphus for the most of the spine. We'll try and go up to the sort of posterior glide barrier and only do a small movement at that posterior glide, which will save us from taking the spine into a major extension position. So that's if we use symmetrical positioning. And we can use our hands and we can use a wedge perfectly well to stabilize that segment. Now, if we want to produce a rotation when we have got symmetrical stabilization, then we're going to have to actually rotate the lever. For example, if I wanted to produce a left rotation of the thoracic spine, I could produce it by actually left rotating like this, stabilizing my caudal transverse processes, and I could produce a rotation. If I wanted to produce a rotation, and this makes a huge difference, no question, we should use a non-congruent lock. And this non-congruent lock, once we've got it for the thoracic spine, is going to be incredibly useful for mobilizing the costotransverse joint and doing a manipulation of that